All right. So I found the morning fascinating because I think we started out with issues of one variable at a time subpopulation analysis, and then heterogeneity in treatment effect, heterogeneity in prognostic effect, and now it turns out it's about patient preference and about physician behavior, and we haven't even gotten to whether the sample that's delivered to the lab was properly handled or the result that came from the lab is correct. So there's certainly a lot of variables here if we start with the original matter of heterogeneity of treatment response and trying to make it generalizable and actionable. I'm actually very impressed with how much heterogeneity there is in every aspect of the system that would intermediate into the results that we wish we could have. So just thinking about heterogeneity of response, I would like to start with what I think is the prototype, sort of really clean, classic. And for that, I would think of the targeted therapies in cancer. Pretty clear cut. There are some therapies where you can clearly state, because of a genetic variant that is targeted, you either have a responder or a non-responder. I'm leaving out the whole part about how good the lab test is. A lot of this, of course, has got a companion diagnostic regulatory approval behind it. So we'll leave aside some of the reproducibility in practice and so on. But it's very directive. It's got a clear implication. It's got a clear pathway. Something I think is very important is that it separates patients very clearly, because it seems to me that a lot of what we struggle off in all decisions, including healthcare and medicine, is what you do in the middle and how you start to separate out the middle into this end of the spectrum or that end of the spectrum. So just thinking about it, to be actionable, what would be required if indeed we can learn more about heterogeneity in treatment response? One is the generalizability. As I've listened, and David, this just may not be my knowing the field, I am unclear as to how much, when we look at heterogeneity, we are thinking about that trial, or are we thinking about that disease or that setting or that patient population. I'm not clear about how this is all going to generalize outside of the specific analyses we would do heterogeneity in specific trials to see what was operative there. Then I think the next question is, obviously this is fascinating after the fact, but really to influence the care, you have to be able to know this before the fact in order to make the decision. So I would say that's another dimension of generalizability. That is, does it generalize outside of the trial, and does it generalize from our analysis to data to prospective decision making? And then I'm going to get back to the separation matter. That is, does it separate into patient groups where the pathway is clear or the pathways are clear? That is, does it really redirect action? And will both clinician and patient and anyone else who may be involved in this decision making actually understand and be clear about what these pathways are? So I believe what we've learned from this panel is not all heterogeneity is equally important, because it may not all meet these, I'm not going to call them criteria, but they're off-the-cuff observations about what makes for actionability. And all of this is before you get into the messy stuff of organizational and individual behavior. And that's, of course, where we get to how the work pathway is organized. When does the lab deliver the result? I'm sorry to keep dwelling on this, but in understanding the companion diagnostics, I learned an awful lot about what might happen to a sample on its way to a central specialized laboratory. There is a lot that can happen that will make that sample uninterpretable. And that was just the sample itself. not the ability to interpret it, to apply it, to deliver the therapy, etc. In this conversation, in the last panel, I thought what was said was very important, but I do want to distinguish between patient preference, which we should know more about, and the heterogeneity of treatment effect. And I thought this was getting a little bit confounded in that conversation, because I think the ultimate point is to know enough about heterogeneity in order that for patients to express their preferences and to have an informed consent. And I would urge us to keep these dimensions clarified, or it really will confound our purpose in that decision making. And then I think that really does sum up some dimensions of generalizability. But I do want to get back to something, and this is more of a, not necessarily a stakeholder remark, but just something that I think about in my dystopian fantasies. But we have a sense that knowing more about heterogeneity will make things more efficient, more precise, less costly. But I think we may not appreciate some of the, I'm just going to call them fairness perception factors here. I think of the targeted therapies. With the introduction of certain targeted therapies, well, let's think in cystic fibrosis with Kalydeco. Suddenly, the world of cystic fibrosis, where there were individuals with the same diagnosis, perhaps different attributes, perhaps different prognoses, but they had the same disease and the same pathways for supportive care. Now we have patients who actually have a treatment for their disease and patients who don't. And it's actually very analogous to some of the things we see. I'll go back to insurance and access, because that has come out. Decades ago, insurance rating and pricing was all done on a community basis. And as I think care got more sophisticated, the costs of that became more prohibitive, or maybe there were other inflationary aspects. I really can't speak to that. But what we have seen happening in the market is an attempt to segment out the better risks. That doesn't just mean medical underwriting, which is now forbidden under the ACA. You cannot be biased by pre-existing conditions. But actually the more important part where this behavior is happening is in what we call self-insurance, where large employers are underwriting their own risk and reducing their own costs and not contributing their probably healthier employers to that general pool. And so I'm just going to leave you with the thought, if we really begin to discover heterogeneity, we may be undoing some piece what we not thought about, but perhaps has been important to affordability and how risk is spread and what the costs of treatments are, which is, historically, I would say, non-responders have in some ways subsidized responders. Companies can make treatments for a large population. They can spread the cost. The average cost is less. We keep saying, well, we're looking for the responders, and when we find that, we may find ourselves in a situation where, in fact, we have higher costs for that drug, and a part of that population that feels left out, disenfranchised, or unfairly treated. Again, that's just my dystopian imaginings.